Pretty already?
I think so.
My goodness.
I don't think this speaker is. We don't have the others. Oh yeah, can we use them on others?
We were having trouble last week. I couldn't figure out how to change the batteries in it. Somebody has already. Testing. This is mic 1.
Okay. So wireless 1. I think I unmuted it.
And I texted him this morning.
I'm not very good.
Testing.
I'm sure
This is actually this one's mic 1 and
yeah, but like it's like.
are you up first? Or is it me? Do I jump right in?
I know that's a cliche.
We don't.
But that's
I guess mine is a little. Mine's
I'm just trying to figure out.
It's not even this left one.
Trying to survive this week, right? Yeah. Oh. That's my every week.
So I think that's. You can shift the battery.
It is. That's my thoughts. Now, do we have?
Alright.
Let me see if I can figure it out here.
I'll go ahead and get started.
Go ahead.
Alright. So many of you, good to see you. Alright, so we finished up all of the kind of pre-stuff. Today we're going to go through medications. Hopefully you guys use some of the weekend to review the different classes. So you have a little bit of scaffolding to put what we'll talk about today on. As a review from last week, what's the major difference between type 1 and type 2 diabetes?
Younger population type 2.
So
Above
that's
30, general, above 30 usually.
So that's a major difference. Type 1 generally is diagnosed in younger people versus type 2. How about mechanistically?
One is autoimmune.
Type.
Type 1 is one autoimmune, and type 2 is resistance to it.
Perfect. So type 1 is an autoimmune disease. So you could test autoantibodies to help with diagnosis versus type 2 is more insulin resistance. And so since type 2 is insulin resistance, there's lots of medications that we're going to talk about today that we can use to treat this, not just insulin, although you can use insulin for both of them. What do we use what are some ways to diagnose diabetes? Above an A1C above what? 6.5.
Goal is below.
The goal is below 7, a point of confusion. How about if we were diagnosing it based off of a fasting blood glucose? Above what threshold?
18.
99.
What that 126?
126.
Yeah, 126.
There's a lot of numbers.
Yeah.
So there was one slide that had a chart that compared all of the numbers for compared fasting glucose versus diagnosis versus the goals. And it's the same for type 1 and type 2. So definitely take a look at that. All right. So we'll go ahead and get started here. All right, so as I said before, we'll try to frame all the questions for the exams based off of these objectives. So if you want to put them into chat, have it come up with some practice questions. That could be helpful to kind of quiz yourself and see what you know. Let's see here. I do want you to be familiar with the brand names for the classes, because this is something that could be on the NAPLEX, and they're very common. So I'll go through the ones that I think are the most helpful for you to know. compare and contrast safety, differences on efficacy and glycemic control. For the GLP-1s, I want you to know if they're dosed once a week versus every day. And then patient characteristics that you would use to help determine which treatment would be the best. And then, given a case, be able to assess what some potential best options would be. And we'll have some practice too. All right, so here, well, you have to really understand each of the classes first. There's not necessarily one first line agent for everything. So we're gonna, here in the next few minutes, go through all of the classes, point out characteristics that you might look for on why it may or may not be a good option for a patient. But we'll look at their glycemic control ability, so their ability to lower A1C, control blood glucose. One of the biggest things that we look at now is their past medical history. So if given a case, that's one of the first things you should look at. Do they have chronic kidney disease? Do they have ASCVD? Do they have heart failure? And use that to determine what might be the best option for them, because we have medications that can help limit the risk of all of those things. The next thing is look for any contraindications or precautions. So again, we'll have a case, and maybe embedded in that case would be a warning or contraindication that would make you then rule out a certain class of meds. We'll talk about medication costs. So we'll talk about which things are less expensive versus more expensive. We'll look at some formularies. And then I list patient preferences last, but patient preference is very important as well. Especially some of these are injectables. Sometimes patients prefer non-injectables. So that can play a big role. All right. So I've got these listed down as oral versus injectable. So that was a good segue to this. So we'll go through all of these classes. This is just the class name for all of them. But I think it can be helpful to kind of have this framework in your mind as we go through. That most of these are oral, but we have quite a few injectable ones as well. And we'll go through and kind of talk about where in the organ systems each of these work as we go through. I'm going to start with metformin, pharmacology of that.
Okay, so again, group number one, we've got metformin. This is the only, this drug belongs to a chemical class called biguanides, and this is the only drug example from that particular chemical class. The name of the chemical class comes from the pharmacophoric structure, the biguanide group right here, which is a key component of metformin's chemical structure. You also see over here, there is a lipophilic tail here at the R1 position that is kind of important for a side effect associated with metformin that we're going to kind of talk about in a few minutes. So again, no real structure-activity relationships here for you to know, except for understanding, I think, how this, the R group here, working. I don't think it's working. At any rate, the R1 group here plays a role in the side effects associated. One of the side effects associated with metformin. Okay, and Dr. Folt's going to tell you this is a very commonly used drug, very effective, and it's got a very kind of unique mechanism of action as compared to some of the other drugs that we're going to talk about. So when we look at this drug's effect at a molecular cellular level, what is its protein target? Well, this particular drug activates an enzyme inside of cells that are insulin sensitive. And that enzyme is adenosine 5' monophosphate activated protein kinase, and that's a mouthful for you to say, so we abbreviate it as AMPK. Okay? And again, on an exam question, I would use that AMPK designation for this particular drug, not the full name. AMPK is probably not an enzyme that you've learned about or talked about, even in biochemistry. but I like to think of it as sort of the energy sensor, okay, or gauge inside of a cell. And it really senses or detects ATP usage, okay? So under normal circumstances, this enzyme is typically activated when ATP levels inside of a cell get low or they become depleted, all right? So again, I like to think of this as like a gas gauge in your car, right? As your gas tank starts to get empty, right? Your screen lights up in your car and it alerts you to a low fuel tank and you've got to go and get gas. So AMPK is kind of like that fuel tank indicator, low fuel tank indicator in your car. It also is an enzyme that can be activated independently from the insulin receptor. So we're going to see what this enzyme does once it's activated. It can actually do some of the similar things that activated insulin receptors do inside the cell, but it does it independent from the insulin receptor, which makes it a unique drug target. So let's take a look here at this particular diagram. And just, it's a little bit busy and complicated, but most of the details here in the middle, okay, I'm not terribly interested in you knowing, okay, that's not what's important here, but I do want to point out and start with the insulin receptor up here. So again, as you're taking notes, you could star this as start here, right? So again, this is an insulin sensitive cell here. We have our insulin receptor, and one of the things about what we see here is as the insulin receptor here gets activated, you've got a complex series of signaling proteins that are activated, which ultimately lead to the insertion of GLUT4 proteins into the cell membrane and allow that cell to take up glucose, okay, out of the bloodstream. Okay, that's what insulin does. So this left half of the diagram here, from the insulin receptor over to your left, just kind of shows you what you already know. Activation of the insulin receptor, lots of signaling proteins get activated, and ultimately glucose transporter proteins get inserted into the cell membrane, allowing for the cell now to pull glucose in from the blood and the extracellular fluid and convert that to ATP. Okay, everybody got that? Now, what's really interesting about AMPK, here it is over here, you can star this. This is kind of part 2. AMPK, like I said, is that energy sensor or gauge in the cell, and it gets activated when ATP levels in the cell are low. So again, for example, if you're exercising your skeletal muscle, right? Lots of muscle contraction, exercise, you're using lots of ATP, and after a period of time, ATP levels can get low in your muscle cells. So what happens? AMPK gets turned on, and look what it does. Okay? It also can stimulate insertion of glucose transporters into the cell membrane. And it doesn't need insulin receptor activation to do that. It does it all by itself. So if you wanted to develop a drug that doesn't utilize the insulin receptor or any of its signaling pathways, okay, but can stimulate cells in target tissues like muscle tissue, fat tissue, and liver tissue to take up glucose out of the extracellular fluid, AMPK is a great target. And again, metformin is a drug, when you take it, that will independently activate AMPK and allow your target cells to take glucose out of the bloodstream. Okay? Does that make sense to everybody? Right, that's independent of any type of effects on it by insulin, and so it gives a kind of a unique mechanism. Now, that's not all that metformin will do. Okay, it turns out AMPK is pretty important in a whole bunch of different things here. Okay, so when AMPK gets activated, I mean, it's got a whole litany of effects in lots of different tissues. For example, the brain. And when AMPK gets activated in the brain, that increases your appetite, okay, and your desire to consume food, which makes sense, right? You're ATP depleted, you need fuel, you want to eat, okay? In the heart, okay, we get an increase in glucose transport into Cardiac myocytes, we get an increase in fatty acid oxidation and uptake and an increase in glycolysis. Okay? So again, all of those associated with AMPK activation in the heart. Okay? Glucose muscle. Here it is right here, an increase in glucose transport. What I just showed you on the previous slide. An increase in insulin sensitivity. It also causes that. Okay? In adipose tissue, look at all the things that it does in adipose tissue, but here it is, increase in glucose transport. Okay? And then over here in the liver, okay, it reduces gluconeogenesis. And I have a star by this because this is a really unique effect of this drug that we don't see in our other types of type 2 diabetes drugs. Okay? So what this does is it inhibits the process that the body uses, or the processes that the body uses to produce new glucose molecules during fasting states. Right? So this drug works at night while you're sleeping, and your body would normally engage in producing glucose through gluconeogenesis. This drug will inhibit that process or reduce it. So that's a very unique feature, hence why I have the red stars there. So what I want you to know on this slide are only the things that are in the tan boxes. That's it. You don't need to know anything else. I just wanted to give you an appreciation for all the different things that AMPK does when it's activated. The ones in the tan boxes are the most important, I think, for you to remember from the standpoint of type 2 diabetes therapy. And here, the effect on the liver, the red star, if you're not going to remember anything else from this slide, okay, please make sure that you remember that it does inhibit gluconeogenesis in the liver during fasting states. And that's a big primary mechanism of action, okay? Right? Any questions about AMPK? Energy sensor gauge. It's usually turned on when ATP levels inside of cells are low, and it has a whole bunch of different effects here in different tissues of the body to help refuel those cells, essentially. Okay? Any questions? All right. In terms of the adverse effects with this, okay, so again, there's some mild GI distress, diarrhea, abdominal discomfort, nausea, metallic taste, weight loss you can see with this, and Dr. Foles is going to talk all about weight gain. Your drugs are weight neutral, cause weight gain or weight loss, okay? The pills are pretty big too. Yeah, they are a little bit, so if you're not someone who likes to swallow large pills, okay, they are a little big. And again, kind of a unique side effect to this would be diminished serum vitamin B levels. And what happens here is that a lot of your vitamin B12 that you ingest, okay, or that's in your intestinal tracts that you need to absorb into the bloodstream, that absorption occurs in the distal ileum of the small intestine. Okay? And it's a calcium-dependent process. So for us to absorb vitamin B12 into the bloodstream, calcium needs to be present. And what we think is happening with metformin as you take it and it finds its way into the distal ileum of the small intestine, that lipophilic tail that I showed you at the beginning will actually embed itself into the cell membranes of the enterocytes that line the small intestine. Okay? And the biguanide group has a positive charge associated with it. So what it does is it repels calcium ions. And so there's not enough calcium present in those regions of the distal ileum where vitamin B12 gets absorbed, and so we get a reduction in the absorption of vitamin B12 and a reduction in serum levels. That we can't see that. Okay, so that's a kind of an interesting side effect that's closely associated with the medicinal chemistry of the drug and its ability to again embed itself into the cell membrane here with that lipophilic tail, and then the positively charged biguanide group, which repels calcium ions, which are needed for vitamin B12 absorption. Okay? All right. Any questions about the side effects or that vitamin B12 mechanism? Yes, sir.
I have a question.
Yeah.
I know that one of the ADRs for metformin is lactic acidosis.
Yeah.
Is there like a proposed mechanism for that?
Boy, I would imagine, I have to look, I don't know, okay? But I'm going to have to go back to this particular slide here and maybe some of the effects either on the adipose or liver tissue? Let me take a look at that and see, okay? No, that's a good question.
And we will talk about that.
Oh, you are going to talk
Not
about
the mechanism.
Okay.
So I think that's a great question.
it. All right.
All right. So metformin for many years has been first line for most patients with type 2 diabetes. I would say that is kind of slowly changing based off of some of the benefits we see with some of the other classes we're about to talk about. But still, due to this being very inexpensive, metformin is something that's like on the Walmart $4 list. You can make a little note to yourself that this is pretty inexpensive. And some of our other agents are $400 or $1,000. So just based off of price alone, it still ends up being first line for many patients. Like Dr. Colhane said, it is a really large tablet, and it comes in 500, 1,000 milligrams, kind of all the size, all of the strengths are large. And so I would say in general, patients often don't love taking it just due to that. And to the metallic taste that Dr. Colhane talked about, and the GI distress as well. One of the reasons it's prescribed so often, though, is it is very effective. And even though I know Dr. Colhane had on his slide that it can cause some weight loss, and it can, especially if someone has a lot of diarrhea or GI distress with it, overall, over time, it ends up being weight neutral. But that's a benefit. Some of our other classes will talk about weight gain with them. So this one is generally considered weight neutral, but it doesn't have any particular ASCVD benefit or any chronic kidney disease benefit. So again, that's part of why it's sort of shifting out of first line, but currently still is. I do want you to be familiar with dosing for this because it's a very common, one of the most commonly prescribed medications. I'm sure on your IPI rotations in the community, you saw a lot of metformin. It's super common. It's typical to start it at 500 milligrams either once daily, or if you look in Lexicon, you can start the 500 twice a day. And then you titrate from there based off tolerability. Another important thing to note is the max dose of this, so if you'll also star that. In general, I tell people just to remember that the max dose is 2,000 milligrams a day. And you should know that off the top of your head. This is a fair NAPLEX question, a fair just patient counseling question in general, because sometimes people think more is better, but due to that risk of lactic acidosis we talked about, definitely more is not better. And 2,000 milligrams is the max. Sometimes you'll see the max is actually 2,500. That's just for immediate release, but there's no clinical benefit in using the 2,500 versus the 2,000. So I just think it's easier to remember that 2,000 milligram cutoff. Let's see here. So renal insufficiency is a big deal with metformin. It doesn't cause chronic kidney disease, but a lot of times people's renal function worsens over time, and then they'll stop metformin, and a lot of times they'll attribute the worsening renal function. Patients will attribute the worsening renal function to metformin, even though it's not metformin that's hurt the kidneys, but it is renally adjusted. So if they go to the hospital and have acute kidney injury, they'll stop the metformin. And in fact, we'll talk about on the next slide, generally in the hospital, everyone's metformin is held. Super important to know that it's contraindicated under a renal cutoff of 30 for the estimated GFR due to risk of lactic acidosis, which can be life-threatening. Let's see here. So I think that's all I want you to know from here is we started at a low dose. The max dose is generally 2,000 milligrams or 2 grams, and its renal cutoff is 30. All right, so I want you to take a quick look. I know you are not big micromedics fans, but I know we've looked at micromedics together in Carolina because I love micromedics. I want you to take a quick field trip over to micromedics. I know it's going to be a lot of clicks, and it's not what you normally go to. I want you to go to micromedics and look up the incidence of diarrhea with IR. Alright, I see people making their way to micromedics. I know it's a little bit of a journey.
Yeah. Scroll down. Back to the, where the actual content is on the page. Where it says gastritis. This is diarrhea.
Alright,
And 53% here.
so if you made it to micromedics and you went to adverse
it's not a
effects, what do you see for the incidence of diarrhea with IR? 53. Exactly what French said. 53%. How about with ER?
10 to 13.
10 to 13. So if you were started on that format, what would you ER. So I wish that they would just take the IR off the market, honestly. Not even have it as a temptation for prescribers to prescribe. But I generally recommend always starting with ER. And a lot of times if patients weren't able to tolerate IR, if you switch it over to ER, they're much more likely to be able to tolerate it. Yes.
What would be the reason for you to end up choosing that IR? Is
The
there a
IR?
situation in which
There's not a situation where I would prefer the IR versus the ER. They just have it taken off the market, and when they put in the order on the computer, they see all the metformins. So I don't even know that people are making a conscious choice of which one they're using. Yeah. There's not any circumstance in which I would prefer to use the IR. Even if patients are constipated and you're like, oh, a little IR metformin might help, generally it just makes them still feel terrible. So that's not even a reason I would use IR. All right. So I talked a little bit about how metformin is stocked in almost everyone that goes to the hospital. So on your hospital rotations, you'll see very few patients that are continued on their home metformin. And this is for several reasons. One of the reasons is a lot of people get contrast dye procedures done in the hospital. And so metformin is contraindicated around contrast dye procedures. You guys might have talked a little bit about contrast dye in the prior module. What does it often cause? Or what can it cause? It can cause kidney injury. Yeah, so that's the reason. If someone is having contrast dye, it can lead to acute kidney injury, and then metformin can cause lactic acidosis in those that have acute kidney injury or chronic kidney injury. So that's part of the reason that this medicine is not used in the hospital, is so that they can do any of those procedures that might require contrast dye. And due to that risk of lactic acidosis. It's very uncommon to have lactic acidosis if you don't also have acute kidney injury. So it's very closely linked to those people that have acute kidney injury. Some precautions that you'll see if you look this up in LexiComp or look at the package insert is they have warnings about hepatic dysfunction. But I wanted to clarify, if you see a patient with hepatitis, for example, or some mild liver dysfunction, you can still use metformin, but it is listed as a precaution. But if you were to see some mild liver dysfunction in a case, that would not be a contraindication to metformin use. Same with heart failure. It's also listed as a precaution, but if someone is stable enough with their heart failure to be outpatient, then they're fine to be on the metformin. If their heart failure is so uncontrolled that they're in the hospital, then that's another reason to hold the metformin. But I wanted to kind of clarify that both patients with liver disease and patients with heart failure can both take metformin. The most common side effects are these GI effects, which you guys looked up for us. And there's several ways to limit these. So we talked about already formulation. So which formulation is best? ER. And then you've learned a lot of these other things in parallel. Take them with food, start with a low dose, and then also just counseling patients to potentially expect it. Like saying it's not uncommon to have some nausea, stomach upset, bloating when you first start this. If you can stick it out for about 2 weeks, it generally gets a lot better. So counseling is a huge deal for metformin. All right. So I put this in here as a study guide. So I would use this to kind of quiz yourself. So I want you to, in your seat, just go through and think about metformin's effect on each of these things. So effect on efficacy, hypoglycemia, weight, ASCVD, renal, cost, and see what you can remember. Don't look back, just see what you can remember from the past couple of minutes.
And then because kidney damage, clear the lactate.
Right.
Okay. Got
Secondary was like GLP-1. They got rid of dehydration of GLP-1, and that caused and that they're on that line, and they ended up I wrote a piece of report on it.
Oh, okay. Well, that's awesome then. Well, not awesome for the patient,
Right,
but it's
but
interesting. It's a very interesting situation, right?
All right. So as far as efficacy, what do you guys think? Is metformin effective? Yeah, it's pretty effective. That means it has about at least a 1% A1C lowering ability. So if your A1C was 8, they can get it to at least less than 7. Does it have a high hypoglycemia risk?
No.
No, and that's due to the mechanisms that Dr. Colhane went over. So it helps kind of sensitize the muscle and reduce glucose being put out into the bloodstream from the liver. So it works in a glucose-dependent manner and does not cause hypoglycemia. Does it have very positive effects on ASCVD? Not really. It doesn't really reduce your risk of heart attack. Does it reduce risk of kidney disease?
Yes.
No, it doesn't. It doesn't cause kidney disease, but it doesn't reduce the risk of it either. And in fact, it's contraindicated under what GFR? 30. And that's due to what risk? Lactic acidosis, which is life-threatening, managed in the hospital. If people get lactic acidosis, a high percentage of them actually die from it. All right, so I recommend using this to help you study with each of the classes. So next we're going to move into GLP-1. My little way of remembering these, what do you see as kind of a common denominator for GLP-1? Yep, they're all times. What else? Pens. Yeah. So these are injectable. So I kind of think of the little number 1 as a little injection needle to help you remember that GLP-1s are the injectable class. All except for one agent, and which one is that? Ribelsis, which is generic semaglutide. But all of the rest of these times are injectable. You do need to know the brand names of these, and if I gave you the brand name Ribelsis, you would need to know it's oral, and if I gave you the brand name of Ozempic, you would need to know that it's injectable. You do not need to know Zoltofi or Soliqua. Those are combos with insulin, and not super commonly used. So if you'll just know Trulicity, Victoza or liraglutide, and semaglutide, which can be Ozempic or Rybelsus. Exenatide immediate release. I saw it's available generic. I have never seen it used. Has anyone else seen it used? Someone, have you? No. Apparently it's still on the market. I almost removed it from the slides, but it looks like it's still there. And liraglutide went generic last year. So there are some generics, but they're still very expensive. So I would kind of think about this as it being a pretty expensive drug class, and patients would need insurance to be able to pay for it. All right, so let's talk about how they work.
And before we do that, very quickly, I want to address Ernesto's question because I think it's a very good one. Just really quickly about the lactic acidosis with this, and I don't even need to go. I'll go back to here. So apparently, what happens is with the lactic acidosis is that lactate, okay, is an important substrate or precursor molecule in gluconeogenesis. It's a non-glycemic source, right? So your liver can take lactate and convert it to glucose via gluconeogenesis. And when you inhibit gluconeogenesis with metformin, what happens to lactate levels in the liver? They start to go up, they get released, and you can get metabolic acidosis due to accumulation of lactate. So that's one of the mechanisms. Now, I was talking to Dr. Foles before. Normally, if you have healthy kidneys, right, your body can take care of that excess lactate, but if you've got renal damage or impaired renal function, that can put you at risk for that. Okay, so yeah, great question on that. It's a little bit. There's some more complicated components to it, but I think for us at this point, that should be enough. Okay, so let's talk a little bit about our glucagon-like peptides or GLP-1 analogs. Again, just as a brief reminder from last week, we talked about the incretin hormones. This is a group of hormones that are critically involved in blood sugar regulation. Yeah, we don't normally talk about them too much in like anatomy and physiology classes, although I think now that's becoming more popular because of the popularity of the drugs. But the incretins, again, are super important in regulating blood glucose levels. They are produced and secreted by the intestines upon digestion of food. And again, we know that they have a lot of different effects. They can suppress appetite. They increase insulin release from the pancreatic beta cells. They slow gastric emptying. We're going to go through all those things. And they also have been shown to promote beta cell health and survival, which is really important in type 2 diabetes because we know over time your beta cell population can decline, which impairs or reduces the ability of the pancreas to make and release insulin. Okay? One of the other things that we see in type 2 diabetics in many cases that the effects of the incretins are diminished or absent. So again, as you're kind of losing tissue sensitivity to insulin and insulin becomes less and less effective, we also see a decline in the effectiveness of the incretin hormones. We talked about two different types of human incretin hormones, GLP-1 and GIP. Those are your two common ones. The drugs that we're going to talk about today share structural characteristics with the incretins, and I'll show you some examples of those in a few minutes. Again, if you understand how the naturally occurring incretins that your body makes work, you know how the drugs work because they're just mimics of those hormones. Again, we have number one is enhancement of glucose-dependent insulin secretion from pancreatic beta cells. So again, incretin hormones in the presence of large oral glucose load can help those pancreatic beta cells to increase their secretion and release of insulin into the bloodstream. Okay, we have suppression of glucagon release. Okay, so the incretin hormones also suppress glucagon, and again, that will suppress glucose release stored glucose release from tissues like the liver. It also slows gastric emptying and gives you a feeling of fullness. And again, some of the weight loss effects of the drug are associated with these things in terms of their physiologic effects. We also talked a little bit about how the incretin hormones have a very short half-life in the blood. Once they're released, they can be broken down very quickly by plasma enzymes called your dipeptidylpeptidase enzymes. And there's a particular isoform, the DPP4 enzyme, which is particularly important in breaking down active incretin hormones like GLP-1 and GIP into their inactive forms. So it's really important as we were developing these drug molecules to recognize that if we don't do something about this, the half-life of these drugs are going to be very, very short, making them very either ineffective or increasing the frequency of dosing to the point where they're not really practical to use. So this is something that had to be dealt with in the development of these drugs. Fortunately, we knew a lot about the structure-activity relationships of the incretin hormones and understood what amino acids were really important for the interaction between GLP-1 and GIP and DPP-4. And so again, using recombinant DNA technology, we were able to swap out some of those amino acids and make those drugs very resistant to the degradation by DPP-4. We'll talk more about that in a minute. Okay. So here we have, we talk about exenatide, all right? This is, one of the, kind of the original types of GLP-1 drugs that were available. This is a peptide-based drug, so again, it's most of these drugs come in an injectable format because of their chemical structure, okay? And most of the drugs we're going to talk about in some way mimic the amino acid sequence and structure of our incretin hormones like GIP and GLP-1, okay? Just for your reference here, okay, here is the amino acid sequence for GLP-1, and here's the amino acid sequence for GIP, okay? Just so you can get a sense of what the amino acids are. You don't need to know that, you don't need to memorize it, but we're going to take a look at some structural differences between these molecules and the drug molecules so you can see what kind of modifications have been made, okay? Now, let's talk about the first one. So we see here up here, I've added in the exenatide amino acid sequence at the top here in red, okay? And you can see here that one of the amino acid residues, this glycine at position 2, is kind of a grayish color, okay? If we compare that to the amino acid that is in position 2 in the GLP sequence and the GIP sequence, we see that they're different. There are alanines in GLP-1 and GIP. This amino acid happens to be really critical for the interaction of the incretin hormones with the DPP-4 enzyme. That's the amino acid that's super important for the interaction and breakdown of those hormones. So what we've done in exenatide is we've swapped the alanine out for a glycine, and that prevents the interaction of exenatide with the DPP-4 enzymes, thus increasing its half-life significantly, okay? So again, in briefer terms, we know what amino acid in these incretin hormones is important for DPP-4 enzyme interaction and breakdown, right, of the hormone. We've eliminated that enzyme, or we've eliminated that amino acid and replaced it with another one that the DPP-4 enzyme doesn't recognize, and now all of a sudden the drug molecule is resistant to breakdown by DPP-4. Okay, so common strategy used with these kind of drugs. Okay. The first two amino acids here in exenatide, the histidine and glycine, okay, are really, really important for the efficacy of the drug, okay, the ability to activate incretin receptors. So again, you will see those two amino acids present in a lot of the drugs that we're going to be talking about because they're important for efficacy. All right. If you remove these 2 amino acids, and we've done studies on this, the remaining amino acids actually serve as the incretin hormone antagonists, which we don't want. Okay? So just kind of a little FYI there about some of the chemical studies. But histidine and glycine, very important for the efficacy of these drugs and their ability to activate incretin hormone receptors and do all the things that we saw on this slide right here. Okay? So we've got 3 amino acids that are, actually 2 amino acids that are really important. Okay? We also know that there are a number of amino acids, residues that exist between position 9 and position 30 here. Okay, you can see the blue amino acid residues here. These amino acids are really important for binding to the incretin hormone receptors. Okay, and there are certain ones on there. So again, we've got histidine and glycine here, which is important for efficacy. Okay. The glycine, which is important for eliminating the interaction that the drug has with DPP-4 enzymes and its breakdown. And then we've got a series of about 21 amino acids here, many of which are really important in forming chemical bonds with the incretin hormone receptor, the GLP-1 receptor. Okay, so we do know a lot about the chemical structure of these drugs. Okay? Semaglutide is another type of GLP-1 drug. It's got a very long half-life, as Dr. Foles is going to talk about. And I just wanted to show you kind of the medicinal chemistry reason for that. So it's very, very similar to GLP-1. It's got almost a 94% sequence homology, so it's just very similar. It's got a half-life of 1 week, okay? So a couple of things here that contribute to that very long half-life, at least 2 things here, okay? We've got an amino acid substitution here at position 8. There's a couple of amino acids before this that aren't shown. But at position 8, there is typically an alanine amino acid residue. And what we've done in semaglutide is to replace that with a kind of an unnatural amino acid residue, alpha-aminoisobutyric acid. So that's what AIB stands for right there. Again, this substitution protects this drug molecule from metabolism by the DPP-4 enzyme. So that's critical, okay? Then we have a chemical moiety attached to the lysine at position 26 right here, okay? And so, again, this chemical moiety here has a spacer group that is attached to a C18 fatty diacid chain. You can see that right here. And what that side chain does, that fatty acid side chain, is that it allows the drug molecule to bind tightly to albumin in the bloodstream. And that's really critical for its very long half-life. It binds very tightly to albumin, it circulates throughout the body, and then it slowly leaches off of albumin over time and starts to impact target tissues, okay? Again, down here there's an amino acid substitution here at position 34 that helps to ensure that the C18 fatty diacid chain that I have shown right up here actually binds to the appropriate spot in albumin, and that binding is tight. I'm not really worried about that. All I really want you to know about this drug is it's got a very long half-life, it's resistant to DPP-4 metabolism, and the reason for the long half-life primarily is because of this fatty diacid chain that is attached to lysine at position 26 that allows it to complex with albumin and slowly unbind and leach off of albumin over time, okay? All right, so are we using the oral form of semaglutide now, Dr. Foles?
Yes, we are.
We are. Okay, so I guess it's a little bit worth, talking a little bit about the stack. salcoprosate sodium, SNAC. So semaglutide is available in an oral formulation, which should surprise some of you because, again, this has been the problem with peptide-based drugs in the past, is that they're always administered parentally because if you administer them orally, what happens to them in the stomach? Yeah, they're broken down, right, by the acid and the pepsid and all that, all those peptidases there that break down proteins. So again, a lot of different strategies have been developed over time to attempt to address this problem so that we can get oral formulations of the drug. What we see is that oral semaglutide is complex with this SNAC molecule, salcoprosate sodium. And what it does is, you can see here, okay, here is a just a cartoon picture of a semaglutide tablet, okay, and it's in the intestinal tract, in the GI tract, and it's slowly releasing SNAC as well as semaglutide. Semaglutide being represented by the blue spheres, and SNAC represented by the tan spheres. And what happens here is that the SNAC molecules actually form a protective complex around semaglutide and prevent it from being denatured by the low pH of the stomach, okay, or by enzymatic degradation by pepsin. Okay, so that molecule again forms kind of a protective layer or barrier around the drug molecule and protects it until it can get into the intestinal tract and get absorbed. Okay, so a very interesting kind of drug formulation there to help create an oral drug formulation that's super important here. So, and any questions about SNAC or what it does? Yes.
So that's what doses have for the formulation to get absorbed. Oh, okay.
Yeah. So this has been very effective in terms of this strategy. Yeah. So again, it's just something about from a pharmaceutic standpoint that I thought was really kind of interesting because again, one of the drawbacks of these drugs is they have to be injected, and people don't like needles and they don't like to take. And I have a feeling, right, some of the drug development is going more and more towards oral formulations.
I think years from now we'll have more oral because it will be less expensive to manufacture.
Yeah, absolutely. Yeah, for sure.
So there's a lot in the pipeline right now.
These are very exciting group of drugs, for sure. Okay. So in terms of, the mechanism of action of, just our incretin drugs in general, I have exenatide, semaglutide there, but this applies to all of the drugs that Dr. Coles is going to be talking about. Okay, from a pancreatic standpoint, we know that the incretin hormones augment or increase insulin secretion from pancreatic beta cells in the presence of a large oral glucose load. So again, you eat, blood glucose levels start to go up, and now the incretin hormones are released from the intestinal tract, and they start to have that effect on the pancreatic beta cells to really boost or supercharge insulin release. Okay. Now, how does that happen? Okay. If we go over to this next slide here that shows a picture of our pancreatic beta cells, okay, we're going to really focus on this light gray rectangle up here. This is where our incretin hormones work, okay? This receptor here, okay, which is a G protein coupled receptor or GPCR, is your GLP-1 receptor, okay? This is where your drug molecule works, okay? So, like drugs like semaglutide, that's where they work, okay? And they activate this receptor. This receptor is coupled to the G protein G sub S, which will activate eventually adenylyl cyclase, okay? And adenylyl cyclase will produce cyclic AMP. If you remember that pathway, you can see that conversion happening here. That will activate PKA, and PKA will phosphorylate and enhance the closure of our ATP-sensitive potassium channels here, okay? Which we know is a key component to insulin hormone release from the pancreas, okay? Remember, normally, as blood glucose levels increase in the body after a meal, okay, glucose absorption into the pancreatic beta cells increases, Okay, we get an increase in glycolysis and an increase in ATP production, and that elevated ATP levels here will close these ATP-sensitive potassium channels. But when your incretin hormones are present, okay, we actually get an enhancement of that closure through the adenylyl cyclase pathway and the PKA activation and phosphorylation. So we kind of get two mechanisms now acting on these ATP-sensitive potassium channels, causing them to close, causing a greater depolarization inside the cell, a greater influx of calcium ions, and a greater release of insulin from secretory vesicles here. So all of this stuff here, okay, that I just talked about is written right here, right, in case you missed some of it. But again, if all of that is gibberish to you and you know you're never going to remember it, please just remember, number one here, that metformin augments insulin secretion, okay, in response to an oral glucose load, okay? It doesn't do anything to enhance insulin secretion when there's low glucose levels or kind of premeal glucose levels, but it only really has that effect on insulin postprandially as blood glucose levels start to go up. Okay, so it's dependent on oral glucose loading. Okay, all right. The other effects on the pancreas is that it also suppresses glucagon release, which is important. That also helps to lower blood glucose levels. We know that in the GI, it slows gastric emptying, and these hormones also have a central nervous system effect where they suppress appetite. So they give you that feeling of fullness, okay? And again, that's probably most likely associated with the weight loss effects of these drugs, at least in parts, okay? Adverse effects here, again, we've got hypoglycemia, we've got nausea, okay, which is dose-dependent. Dr. Foles is going to talk a lot about that in terms of what kind of doses you start your patients off initially to kind of avoid or help them adapt to the feeling of nausea, right? We've got acute pancreatitis, which is a problem with this. And again, one of the other side effects that we hear all the time in the news is gastroparesis, which I don't have up there. But I think, Dr. Foles, you're going to talk about how common that is?
I will.
Okay, great. So again, those are the adverse effects. Right? Any questions about incretin drugs? Okay, at least know what the 4 physiologic effects of those are. That's a key piece. Okay, the effects on the insulin secretion, decreasing appetite, slowing gastric emptying, effects on glucagon. Okay, those 4 are really important to know. Okay.
We'll finish out this class and then we'll do our break. So I'm glad that it says hypoglycemia on this slide, because if you look in lexicon for micromedics, hypoglycemia is going to be listed for all the type 2 diabetes medicines, anything to treat diabetes. Same as hypotension will be listed for all the blood pressure medicines. However, based off of the mechanism that Dr. Fulhane mentioned to you about the glucose-dependent effects of this class, it's considered a really low risk of hypoglycemia, same as metformin. So I just wanted to point that out because it is listed there, but due to the mechanism, it's a low risk. So I apologize, when I was updating these, I missed this here. So if you'll update it for cost, I actually told you that kind of 2 of them are generic. Which GLP-1s did I mention earlier have gone generic? Liraglutide, which is brand name Victoza. And then I told you exenatide immediate release. There used to be an exenatide extended release too, but it was removed from the market either this year or last year. However, liraglutide and exenatide, they are still expensive, just like we talked about before. So there are some generics, but still expensive overall. These have great reductions in A1C, so especially semaglutide and dulaglutide are 2 of the most effective, most potent ones. So they have more A1C lowering than even metformin. And these agents have benefits to other organ systems. So you'll see for cardiovascular benefits, so they actually have studies that show they reduce the risk of heart attacks and strokes. in patients that have type 2 diabetes. So liraglutide, semaglutide, and dulaglutide all have this benefit. And then have benefits even in chronic kidney disease, especially semaglutide probably has the best evidence. We'll talk about another class that's more highly recommended in chronic kidney disease, but these also have some emerging data as well. One thing I don't have on here is actually even fatty liver disease. These agents, because they help with weight loss, have some benefits in metabolic liver disease as well. And so there's some emerging studies on benefits for other disease states as well. Let's see here. Are there other things? Oh yeah, other indications. We'll talk about obesity at the end of diabetes, and we'll talk about some of these are approved under one brand name for type 2 diabetes and another brand name for obesity. Does anyone know any brand names for the obesity? Wegovy. Wegovy's brand name for which one? Semaglutide. Yeah. What's another one? There's 3. Victoza has one. Does anyone know the brand name for Victoza for weight loss? Saxenda. And then there's one more. Sort of. We haven't talked about this class yet. It's not just a GLP-1.
Oh, tirzepatide.
Tirzepatide, which we'll talk about next, which is Zepbound. All right. So here's the chart again. So if we're looking at the GLP-1s, they're very effective. They have low hypoglycemic risk. They have benefits for cardiovascular disease, emerging data for renal benefit. So what do you think their place in therapy is? They're used commonly, not commonly. What do you think?
Maybe smart company.
Yeah, these are very common. So I don't know the percentage of patients with type 2 diabetes that are on a GLP-1, but very high. And I think if these were cheaper, they'd probably be the first line agent instead of metformin. So they're right up there with metformin, used very often. Kind of the main drawback is the cost of these, because they have so many benefits. All right. So I do want you to be familiar with this chart with knowing the frequency. So exenatide, the very first of these to come to market, is actually dosed twice a day. This is not even, it's very rarely prescribed. I, in the past 10 years, have not seen any patients on exenatide. So, but it's still on the market apparently and went generic this year. Then there's once daily Victoza or liraglutide. This also is not super commonly used because it's dosed every day, and until this past year, it's been brand name only, so very expensive. I do wonder, since it is generic, if maybe more insurance companies will put it on formulary as preferred, but I haven't really seen that happen yet. So I do want you to be aware that liraglutide is dosed once a day. You don't have to memorize all of the dosing for it, but I want you to know the frequency. Then we also have the semaglutide oral tablets that are also dosed every day. I put the dosing for the originally approved Rybelsus, but there's actually a new formulation of Rybelsus on the market. Has anyone seen the new formulation? No. I'm not sure if it's available or not. I don't have any patients on it. When I checked a few months ago, pharmacies couldn't order it, but there's actually a new formulation of Rybelsus that's supposed to be better tolerated. That's supposed to hit the market at some point. All right, and then what's used most commonly, and probably the ones I would start and spend the most time on, are the weekly ones. So dulaglutide, which is Trulicity, and semaglutide Ozempic are once a week injections. So I think you guys learned in Care Lab how to counsel on one or both of these products, for sure. Yeah. So Trulicity are the single-use pens. Ozempic is more like an insulin pen that you have to titrate up to. So are really critical medicines to counsel patients on how to use. I'm not going to go through how to use them here, since you guys learned that in Carolyn. As Dr. Colhane had in his side effects slides, GI are the most common side effects. Metformin I kind of think of as being more typically diarrhea, gas, bloating. The GLP-1s are a little bit more like nausea, vomiting, but they can overlap, they can have very similar side effects. Similar to metformin, starting at a low dose and increasing it slowly is one of the main things that we do to limit these side effects. So you'll notice with all the GLP-1s, the oral and the injectable, you'll start at the lowest dose, and then you'll titrate them. So also similar to metformin, if you can tolerate them for the first couple of weeks, it generally gets much better. Or what I should say is if you don't tolerate them very well for those first few weeks, if you can stick it out, generally with each subsequent dose, you tolerate it quite a bit better. To limit some of the feelings of nausea, eating smaller meals can help patients because it's slowing down that gastric emptying. So that can help as well. Other side effects here, like Dr. Colhane mentioned, is they can potentially cause acute pancreatitis. So if you have a patient's case where they've had a history of pancreatitis, we generally will avoid this class. It's not quite a contraindication, but if they have a history of pancreatitis, it is more likely that they might have another case. And we have some other contraindications that must be on the next slide. These like eye complications are also emerging. There was a study that came out earlier this year on some diabetic retinopathy and different eye conditions that have been associated with this class too. So there are some scary side effects that patients see on these, and it is recommended for patients to have routine eye visits with their ophthalmologist on these medications. Let's see. So, weight loss is generally considered a benefit with these. You get the most weight loss with semaglutide, but really all of them are associated with weight loss. The only true contraindication is this risk of thyroid cancer. I always tell patients, out of an abundance of caution, if they have a personal or family history of thyroid cancer, we don't recommend these medicines. It's from studies in rats that got high doses of this. We haven't really seen it pan out clinically in patients. I've never had a patient that ended up with thyroid cancer from one of these medicines. But we just don't want to start patients that might be at high risk of thyroid cancer on these in case it does increase that risk. Other things, if you see in the case that they have pancreatitis or gastroparesis, or even gallbladder disease, these are precautions as these could worsen these conditions. The gallbladder disease is particularly interesting, and actually just rapid weight loss can cause gallbladder issues as well. So not a contraindication, but it is a warning. All right, just a couple more slides on this one. Okay, yes. Yes. You can potentially still use them, but it's a precaution. So if I had a patient with a history of pancreatitis, I probably wouldn't use it, but I have had a few. It's not a complete contraindication. Gallbladder disease, if I have a patient that's already having gallbladder issues, I'm not going to start this, but a lot of people have their gallbladders removed, and so I'll start it after they've healed from that procedure. So that's kind of the difference with gallbladder issues is a lot of times if people have pre-existing gallbladder issues, they end up just getting their gallbladder removed, and then it's not as much of an issue. So it just depends. If they do have gastroparesis, again, it's not a contraindication, but they're probably not going to tolerate the medicine very well. So in general, I'll avoid it for those people, or I'll just keep them on a really low dose. So it's kind of a gray area where they might still be on it, but it should definitely be a red flag. I think for your purposes, if you see any of those things in a case, avoid them. All right, so a lot of patients that are on insulin will actually add in GLP-1, and it can help sensitize them to the insulin, help us use lower doses of insulin. So that's one thing I wanted to point out, that a lot of times these are used in addition to insulin. And if you have a patient on insulin and you add one of these, a lot of times they'll need a lower dose of insulin. And so if you keep them on the same dose of insulin, that can sometimes cause hypoglycemia. And it's not really because the GLP-1's causing it, but they're just more sensitive to the insulin dose that they're already on. You do not need to memorize these, but I did want to make you aware that it does come in two formulations with insulin. So Zoltofi and Soliqua are combinations of GLP-1s and insulin together that are on the market, but not super widely used. So you do not need to memorize the brand names of those. Yes.
Insulin is usually for patients.
I'm actually going to let you guys go on your break, and we will restart at 3. What do you think, Dr. Colby? 3:50?
Sounds good.
You just go. Sorry. Quit singing, bro. Look at me.
Yeah, so
You don't like it? Te vas a como papita le salga de
yeah. Well, actually, probably very few, if any of them. All the students out there when you were on your community, were probably yeah, that was just okay. Are they going way back here in this corner? It is actually. Yeah, Christian. I was going to give them a little printout.
Oh, okay. Is there anything you need from me?
Nope, I don't think so.
Okay.
No.
Very cool.
Yeah, so we'll just start. I'll be back. Face. We'll just have 2 at a time. And then we'll go to DPP.
Fantastic.
Think about it. You need to be beat up. Have you? Hey.
Make it realistic. I was like I'm riding the bike.
Not realistic. So like,
Do y'all see Jose out there? Look at his shoes. Toes down.
yes. Oh. Me too.
Yes, sir.
Thank you for asking, answering my question.
Oh, yeah, no problem. That's, I mean, it was a good one. Yeah, definitely, for sure. And no one's ever asked that before. I'm like, that's a really good question.
Yeah, because I saw it in CKD and I was like,
Yeah, and it's, I mean,
they're going to expertise.
yeah, no, it's, not on everything for sure. Very few things actually, but no, it's really, I really like the question because it really ties into one of the primary effects of the drug, which is looking in
Yeah, I was thinking about collagen,
Yeah.
but I didn't know that lactate was part of the.
Yep. Yeah, it's one of those non-glycemic sources that it can make glucose from. So yeah. So it's really interesting. Yeah.
Okay. Thank you so much.
You're welcome, sir.
I have a yellow.
I have one. I need a.
Oh my god. Do you think I can make another one or that's it for today?
How many?
One.
You want to stay today?
No, I don't want. I want to
They-
stay. That's the idea.
Max goes for companies for 100. But if we take it now, maybe we can stick to it. Maybe you have a time. Maybe you have like.
No, just one. Ask Alexi then.
Yeah, they have told me it's really good. It's like
Yeah, my favorite. Especially with dark chocolate.
ooh, that sounds so good.
Just like that.
Oh, good.
My house. I did.
No, I didn't. From here.
Like
Yeah, me too.
possibly we're gonna be.
I did. Yeah.
You're gonna do fine. But they told me that it's hard because they're old school. I don't know. That's what happened. That's what but I think
2 minutes.
yeah, we're gonna be good. How can I'm just I have a practice. Yeah, they have a lot of money in the so you see a lot of things maybe all
I think that's why.
yeah. Maybe I'll find out because I forget about I didn't. Oh, yeah.
Very nice.
Yeah. Apple is big.
I'm trying to decide whether I'm actually gonna do it or not. And I thought about it.
Oh, because you were talking about like the financial genomics.
Yeah.
Oh, for the
Yep.
So I was trying to listen
At all?
Guys.
No audio last week. Okay. What day was that? Last Friday. How about the Wednesday? The first day.
We have more people than us than we do things to be. So I'm leading regulatory chair.
The Wednesday recording. If there's no audio there, let me know. Because there might be a problem with the system.
Alright, we're ready. I think it's probably we don't have a microphone.
And so it wasn't picking up anything. Like our voices aren't loud enough.
I was thinking
I mean, it could definitely be. Let me, I'm gonna ask Sean. Yeah, definitely. Let me.
Because, yeah, either that or maybe there's a different Panopta setting we should be using.
Yeah, no, definitely.
Alright. So I think you guys all a 3-page handout. Bring it tomorrow as well because we'll use it. If you go to the second page, there's a chart that compares everything. And actually, if you know these 3 pages, you might not make 100 on the exam, but you could do pretty well. However, I give this as a gift every year. And somehow, I don't know that it's really received in the way that I wish that it was. So, please use it, kind of quiz yourself on it. I wouldn't reread it a million times, but I would try to see if you can kind of fill out some of these things without looking. And we'll use the last page when we talk about insulin later on. So tirzepatide, I think of tirzepatide as being very similar to the GLP-1s. And a lot of times when I say GLP-1s, I mean tirzepatide as well. Dr. Colhane is going to talk about the mechanism behind it, but it's kind of an ultra-potent GLP-1, because it's a GLP-1 GI. So it's the newest one in this class of GLP-1s. Mounjaro is the brand name for it, and it's currently the only one in its class. Although, like we said, there's a lot of ones in the pipeline. So I'll turn it over to Dr. Colhane to share the mechanism.
All right. So again, as Dr. Full pointed out, this is essentially, a GLP-1 drug. I like to think of it on steroids, a GLP-1 drug on steroids, right? So it's got the same type of effects as your traditional GLP-1 drugs, but those effects tend to be more enhanced because of the chemical structure. So this particular compound is a peptide chimera. It's a combination of an incretin GLP-1 hormone and a GIP-1 analog. So we have two of the incretin hormones that are smashed together, okay, to form one type of drug. So it's sort of like, a peanut butter sandwich, okay, as compared to peanut butter and jelly, okay? So, we get more bang for your buck with tirzepatide. This drug, again, you don't need, look, I'm not going to give you any kind of structure-activity relationships about this, just to show you kind of the complexity of this particular compound, and to show you, the 2 molecules that are connected together here, and again, how they're modified to prevent DPP-4 breakdown or rapid DPP-4 breakdown. So that's all I want you to know. And so the enhanced effects that we see with the combination of these 2 hormones kind of coupled together in one drug molecule is enhanced increased hormone effects. We get a synergistic effect because of the GIP and GLP-1 effect. So again, we can see all of these things here that we talked about, and even some more with the increased hormones. Again, we get an enhanced, decreased food intake due to more appetite suppression. Kind of a increased insulin secretion over just GLP-1 analogs by themselves. There is enhanced lipid metabolism associated with tirzepatide as compared to some of the other GLP-1 analogs that we talked about. An enhanced effect on beta cell survival, increased cardio protection. There's a lot of good stuff with this. It's really, like I said, kind of a GLP-1 agonist on steroids, essentially.
It looks like the magic drug.
Pardon me?
It looks like the magic drug.
Magic drug. Yeah, a little bit of little bit of magic there, right? Yeah. I think so. Yeah.
Very good.
All right. So let's talk about some of the magic and maybe non-magic.
All right. So this medication was approved just 3 years ago. Like I said, it's our newest agent for type 2 diabetes. And it's been added to a lot of formularies. I would say at first when it came out, a lot of times people had to try and fail one of the other GLP-1s like Ozempic or Trulicity. But I'm seeing that that's less and less the case now, and sometimes this will be covered right off the bat. It just depends on their insurance formulary. Really, all these GLP-1s are about $1,000 a month, so it's not necessarily any more expensive than the other GLP-1s. They're all really expensive. Quite effective at lowering A1C, but this one by far has the most weight loss compared to all of the GLP-1s. So quite a bit more weight loss than even semaglutide. Everything on this slide should be very similar to what you've seen on the GLP-1 slide. There's only a couple things that are different. One of these is kind of the specific warning about bariatric surgery. And actually, this is something that could potentially be a warning for any of the GLP-1 agents. And in recent years, they've started putting recommendations really before any surgery about potentially holding these agents. That's due to some of the risk of gastroparesis. And then there's also the risk that after bariatric surgery, there is actually a spike in natural GLP-1. So there's a specific warning with tirzepatide. Not that you couldn't use it later on down the road, but I wouldn't probably use it right after bariatric surgery. All of these have the warning about gastroparesis, but it could be even more potent with this one. So all the side effects and the benefits can be a little bit more potent with this agent. The other thing here is birth control. So it's recommended due to that gastroparesis and slowing down of gastric emptying is to use backup birth control if you're on an oral contraceptive for 4 weeks after starting this or increasing the dose. This medication comes in 2.5 milligram increments, and the max dose is 15. So I'm going to have you at your seat calculate for me. If you're starting at 2.5 and going up in 2.5 increments to the max of 15, I want you to write down to yourself how many months you think it will take them to get to the max dose if you have to go up every 4 weeks.
Well, every 4 weeks.
You go up every 4 weeks.
24 months, 24 weeks.
You're going to have everyone calculate it themselves. You go up every 4 weeks by 2.5 until you hit 15. How many months? All right. What are you guys getting? So 15 divided by 2.5.
That's six.
It's 6. It's 6 months.
6 months.
6 months.
Yeah, 6 months.
Yeah. So I just point that out because if you have to use a backup contraceptive for 4 weeks after a dose increase, you'd really need something for the next 6 months. So probably would make sense for them to try a different form of birth control, especially during that 6 months that they're getting titrated up on this. And it's not uncommon for people of childbearing age to be on this medication. Yes.
So for the medication that Citrus one has, that's specifically not for life.
Yeah,
Is it that it is increased with this one?
It's specifically with this one, I think just because it's so much more potent. They don't have this warning with the other GLP-1s yet that I've noticed. That doesn't mean that they won't add it eventually, but specifically I've only seen it in the package insert with this, with Tridecatine. Yeah, that's a great question. All of these other things are the same for all the other GLP-1s, except for that birth control. All right, so moving on to DPP-4s. Our gliptins.
Our gliptin agents, okay. So I have two examples in this category that I want to talk about that, again, are similar but have some differences in terms of their chemistry, which contributes to their effects. We've got sitagliptin, which was the first drug I remember coming out in this particular category. We have the pharmacophoric structure of our DPP-4 inhibitors here. 2 substitution points, one at R1 and one at R2. And they are both very important for the effects of the drug. So we take a look at sitagliptin here. We've got a 2,4,5 trifluorophenols group here at R1. So this is very, very important for binding of the drug molecule to the DPP-4 enzyme. Okay. And then we've got a trifluoromethyl group here at R2. Okay. And again, both of these will maximize potency and bioavailability, okay, for these particular compounds. But the binding group is here. We take a look at, and one of the things that I wanted to say about this is that this drug binds reversibly to the DPP-4 enzyme. So it binds and unbinds in a matter of minutes, okay? It's got a really good oral bioavailability, and it is renally eliminated unchanged, so it's not metabolized, okay? It's not metabolized. So a couple of things about that. The binding is going to become important because when we take a look at the other compound here, saxagliptin, it's very, very different, okay? Saxagliptin is a vinyl substituted DPP-4 inhibitor, okay? So you can see here the R2 substitution is very, very different than in sitagliptin, okay? Now, the chemical differences between these two drugs, in saxagliptin, the vinyl substitution and some of the other chemical differences allows the drug molecule to bind covalently to the enzyme, okay? And that's what I mean here by improving the stability. We're improving the stability of the binding between the drug molecule and the enzyme. And what's really fascinating about this is even though a covalent bond forms between the drug molecule and the DPP-4 enzyme, it's a reversible covalent bond, which we don't often see. We always think about covalent bonds being irreversible or unbreakable under physiologic conditions. But there's a special category of covalent bonds that are breakable under physiologic conditions, but they break very, very slowly, okay? So this drug will stay bound to the DPP-4 enzymes for hours as compared to minutes, okay? You know, sitagliptin binds reversibly, non-covalently, it binds the enzyme, it comes off in minutes, okay? Whereas saxagliptin, okay, binds covalently, and that covalent bond is unusual because it is reversible, but it takes hours for the bond to break. Right? So you get a much tighter, more stable binding with this drug molecule. That makes saxagliptin much more potent. Okay, so when I don't know if Dr. Foltz is going to talk about the dosing and all with these, but there's like a 20-fold difference, 100 milligrams versus 5 milligrams in terms of some of the dosing. So again, relating some of the medicinal chemistry to the pharmacokinetic parameters of the drug. Now, how do these drugs work? As I've already alluded to, they inhibit the DPP4 enzyme. Okay, so they help to boost naturally occurring levels of our incretin hormones in the body. So we get that kind of incretin hormone effect without a GLP-1 like drug. Okay, and again, as GLP and GIP levels start to increase, we get all of the incretin hormone effects. Okay. We get an increase in glucose-mediated release with that, and we'll see some of the other effects that we see with the incretin hormones. Okay. Here are some of the adverse effects. I don't have any mechanisms for these adverse effects, so what I want you to do is just go with what Dr. Foles talks about. Okay. So you can kind of actually, if you want to make this simple, you put an X through this. Okay. And not worry about it because I really don't have any mechanistic explanation.
I wouldn't X it out as if these are true.
But they are true?
We just don't know what the mechanism behind them is.
So I didn't know if it matched with your list or not.
These are all true.
They're all good? Yeah, it's weird, like nasopharyngitis, right? The upper respiratory tract infections.
Unclear, why that.
Yeah, why that happened. So, okay, I think that's it for me.
All right. So these work on incretin, similar to GLP-1s. So do you think that you would use this class with a GLP-1 or the GLP-1? No. So that's one thing that I wanted to emphasize is using a DPP4 inhibitor and using a GLP-1 together would be a drug interaction. It would be kind of like duplicate therapy. In hypertension, what do you think it's similar to if you were making a comparison? An ACE and R. It'd be almost the exact same type of interaction. So it's not like it's going to kill the patient, but it's no added benefit and potential increased risk of side effects. So that's one thing I wanted to point out. So we talked about GLP-1s are pretty commonly used in type 2 diabetes, as in, it's right there with metformin, used quite a bit. If you can't use a GLP-1 and a DPP-4 together, do you think that these are used very often? No. So this class is not used super often because most people are on a GLP-1. So then you're not able to use this class. So I want you to kind of keep that in mind when you're thinking about these DPP-4s. What's nice about them is they are oral, but they're still pretty expensive. More and more of them are coming generic. So I think this year, actually, Allogliptin's generic, and I think there's a couple others that are generic as well. I'll double check them and get back to you on which ones. I'm not seeing them commonly used. I don't commonly use them. And even the ones that are generic are not super cheap, but still not a good option if someone has no insurance. Some of the reasons we use DPP-4s, or we use GLP-1s over DPP-4s, maybe you can tell me by looking at this chart below. If you were picking a DPP-4 versus a GLP-1, what are some advantages GLP-1s have over the DPP-4? I'll let you look at the chart.
The A1C lowering and stuff.
Yeah, GLP-1s have higher A1C lowering, so DPP-4s have a much lower impact on lowering A1C, so they're not as effective. What's another kind of downside of this class versus GLP-1? Weight loss. These are actually weight neutral. So they don't cause the same weight loss that you get with GLP-1s.
And a lot of times for type 2 diabetes, you want that weight loss to improve insulin sensitivity. What else?
Is the renal adjustment or GLP was also renal adjustment?
That's a great point. Most of the DPP-4s require renal adjustments. And I think I have a little tidbit about this. I'm not going to have you memorize dosing for DPP-4s, but most of them come in multiple dosage strengths. But actually, you start these at the target dose. You don't start low and titrate. This is different than everything we've talked about up to this point. Metformin, GLP-1s, do you start at the target dose of either of those? No, you start low and titrate. These you actually start at the target dose. The only reason there's lower doses is to adjust for renal impairment. So it's kind of like an unusual thing about these DPP-4s. Anything else that you can see that's might make them less favorable than GLP-1?
They're not cost effective.
Did you say cost effective?
Yeah.
Well, the GLP-1s are really expensive too. So both of them are expensive. Yeah, the cardiovascular benefit. So these don't reduce risk of heart attacks and strokes like GLP-1s. What else do they not help? Yeah, they don't help in heart failure. In fact, saxagliptin has been associated with increased hospitalizations due to heart failure. And they don't prevent chronic kidney disease. They can be adjusted for chronic kidney disease, but they don't prevent. So what are some reasons we might use this? Really, if a person can't be on a GLP-1, then this could maybe be an option for them. They are very well tolerated, so they don't have the same GI effects that GLP-1s have. They don't cause that nausea, stomach upset. So overall, this class of meds is really well tolerated, but they're just not terribly effective and don't have a lot of benefits. I point out the dosing. Januvia is probably the most commonly used DPP-4, and it comes in 100, 50, and 25, but you always start at 100 unless they have reduced renal function. So the 50 and 25 are only for people with reduced renal function. I would say this is often misprescribed because when providers are ordering this medicine, they see all the strengths, and so they naturally start with the lowest and want to titrate it, but that's not how this medicine works. One DPP-4 does not need any renal adjustments, and that's Tradjenta or linagliptin. It's 5 milligrams per everyone. So I feel like these are the types of questions. Sometimes they'll ask this sort of thing on the NAPLEX exam on these renal adjustments. So as far as similarities to GLP-1s, both of them can be associated with an increased risk of hepatitis, not hepatitis, sorry, please erase hepatitis from your mind, of pancreatitis. And so if a patient had a history of pancreatitis, you would avoid both classes. But what do you not see as a contraindication for this class that we saw for GLP-1? The thyroid carcinoma. So this class does not have the T-cell thyroid cancer risk or the medullary thyroid cancer that the GLP-1s. So that's one major, safety. All right, moving. What questions do you guys have about DPP-4? Just not used super commonly. But we use these SGLT2s all the time.
Yeah, these are another exciting group of drugs, right?
They are.
Yes. Yeah, and that's something that's really, I don't think you guys don't have the perspective of this. We talk about this oftentimes. This is probably the one disease state outside of oncology where there's just been, at least that I teach in, there's been a real explosion in the number of new classes of drugs that are available. I'm not talking about adding, new Me Too drugs to a pre-existing class. I'm talking about like brand new classes. When I first started teaching this, a couple of decades ago, we didn't have SGLT2 inhibitors, we didn't have incretins. I didn't talk about that. We didn't even know about those sorts of things. And so, there's been a lot of really exciting advances here with this. All right, so SGLT2 inhibitors. Where did you hear about these before? Heart failure, right? Okay, and we didn't talk about the mechanism of action in heart failure because it's very speculative right now. We're not really exactly sure what's going on in that particular disease state, but we do have a good sense of how these drugs work in type 2 diabetes, and so we'll talk a little bit about that. So, just kind of the interesting background about this, these molecules actually come from a natural source, a compound that is found in apple tree root bark, and so that was kind of the starting compound for the development of these particular drugs. When we take a look at the molecule itself and the pharmacophoric structure, it's got two components to it. It's got a glycone, or well, I'll show it to you. We have a glycone moiety here, or a sugar. This is the sugar component of the molecule right here. And then we have an aglycone moiety over here. This is the second part. So this part over here in red, and then this part over here in green. Okay? They are attached to one another. This is really important, by a C-glycosidic linkage here, carbon-carbon bonds. Okay, when you look at some of the original drugs, and even the compound that was isolated from the apple tree root bark, these two components of the molecules in those older formulations in the original compound were actually connected by an O-glycosidic linkage. So we'd have a carbon-oxygen-carbon bond here. And the problem with that is that those compounds would get broken down very rapidly in the intestines by glucosidase enzymes. Okay, and so they had very poor bioavailability. And so as the compounds began to become more and more developed and studied, we realized if we replace that O-glycosidic linkage with a C-glycosidic linkage, like you see here, carbon-carbon, that eliminated breakdown in the intestines by the glucosidases and significantly improved oral bioavailability. So that was a big kind of leap forward in the development of these compounds to make them therapeutically useful. Okay, and again, I have all that stuff right here under 3 and 4. Okay, the part of the molecule that binds to our target protein, which is the SGLT2 protein, is the glycone moiety right here. Okay? This mimics glucose, which is one of the molecules that actually binds to the SGLT2 protein. So, again, that's the part of the drug molecule that will bind in place of glucose. And I'll show you the mechanism of the drug here in a second. Another thing to keep in mind here, you can see that there are a number of substitutions over here on the aglycone moiety, R1, R2, and R3. These substitutions, again, depending on what you put in place there, will affect the potency of the drug molecule and the selectivity of the drug molecule. So substitutions here, R1, R2, and R3, okay, will impact potency and selectivity, which is something I don't have written down on the previous slide, but I'd like you to remember that, okay? Everybody got that? All right? So again, substitutions at R1, R2, and R3 here can again impact potency of the drug as well as selectivity. And there's a lot of different SGLT2 inhibitors out there that again vary in the substitution in these areas, okay? And then the glycone moiety binds to the protein. That's part of the drug molecule that binds to the target protein. Okay? So again, what we see here is these are just 4 different SGLT2 inhibitors, okay? Just to kind of show you, you can see here again in all of them, here's the glycone moiety. You can see that right here, okay? Right here. You can see it down here, and empagliflozin right here, and dapagliflozin here, okay? And Then you have a slightly different glycomoiety here or tuberculose. And then in the A glycone, you can see the differences again in substitutions when you look at, my laser pointer's not working here, between canagliflozin, okay, and empagliflozin. Again, those differences really impact potency and selectivity of the drug molecules. But they all work essentially the same, okay? So let's take a look here at the mechanism of action. The molecular target in type 2 diabetes is the SGLT2 transporter protein in the kidney that's located in the proximal convoluted tubule, okay? You remember, okay, we just had renal, right? The proximal convoluted tubule is able to reabsorb just about 90% of all filtered glucose, right? And about 65 to 70% of all filtered sodium, okay? And the protein responsible for that is the SGLT2 protein. Okay? So if the drug's on board and present, it will bind to the SGLT2 protein and inhibit it, okay? So let's take a look at a picture here, okay? Again, on the left here, we see a picture of our nephron, okay? And you can see here's the proximal convoluted tubule right here. And if we look at a magnified picture, cartoon picture that I drew here, okay? We can see here is our SGLT2 proteins, okay? And these proteins can bind to a molecule of glucose and a molecule of sodium and transport them both from the tubule and into the bloodstream, okay? And our drug molecule here, okay, binds to the glucose binding site here and inhibits the transport of glucose, okay? And so the glucose stays in the proximal convoluted tubule. It goes through the loop of Henle. It goes through the distal convoluted tubule into the collecting ducts and is eliminated in the urine. All right? So everybody got that? And so it's just a mechanism for helping the body eliminate excess glucose. Okay? Okay. Lowers blood glucose, and it also can cause glycosuria, polyuria, and a reduction in blood volume, again, due to the elimination of the glucose from the body. Okay? All right. Looks like we are past time here a little bit. But maybe we'll pick up here again with physiologic effect tomorrow. Okay? Ooh, that one.
I know.
So for the, just one question. For this one?
Yeah.
Is it selectively?
Yeah, so you'll see, as you look at the next slide, and you see some of the other compounds, okay? You're going to see lots of different substitutions for each place. And all I want you to know is that what that does is it changes those, right? So, and I don't even care that you know which one's more potent, but that's not, they're all very therapeutic. But that's the reason why.